Good afternoon. This is Dr. Bill Bird, Chief Medical Officer at CGH Medical Center. Thank you for joining me for Facebook Live today. So today format is going to be, we're going to give you a brief update of what's going on here at CGH and a little bit around the country in terms of the COVID pandemic. And then and of course, as always, we'll take any viewer questions as we're going through my conversation. And then when I get done with that, we're going to be doing our Growing Healthier series. I've actually, Dr. Alsayed, who's our new oncologist working with Dr. Ali Khan. I had a chance to interview him just within the past week. And so I'm going to play that Dr. Alsayed interview after I get done with my updates. And by the way, the interview is, I think it was a pretty interesting conversation with him. It's on the latest advances in cancer treatment. So, as usual, though, let me kick off with pandemic-related information. So, I'm going to first start with our graphics. So, this was as of January 14th. So, we're a week, close to a week out from that. See some numbers, and when we look at these, we're looking at trends. We're not looking at absolute numbers. We're just it gives you a sense of where things are at. I think there's a couple other graphs we want to show you too. So this is as of January 21st. So this is, So it's kind of going back in time, and 2020 through 2022. I was reading that wrong. So yeah, you can kind of see the averages comparatively. Let's move to the next one, Matt. Okay. And so on this one for Whiteside County, I'm going to key in on the middle. Well, actually the middle, all of those, you'll see towards the tail end there that those numbers are trending just ever so slightly down. And thanks, Matt. And that's what we're seeing here at our hospital at CGH, is that, yes, the hospitalizations are up compared to where they were at, let's say, in June, July, and August, and early August. However, they definitely are sliding down from where they were at a couple weeks ago. So still higher than we'd like, but not as high as they were a couple weeks ago. As always, if you want to see our actual daily numbers, you can actually go on to our website and go into it, and under COVID, and I think it's under patient summary type of stuff. And you can pull up and see how many patients we have every day with COVID here at CGH. Oh, thanks, Matt. And then what else did I want to throw out some number wise? Oh, and so I think the thing that let me give you some numbers. So once again, some of these trends that I think are encouraging. So for the state of Illinois, yesterday, the numbers I received from the Illinois Hospital Association was that we had 6,570 people in our state, 6,507 that were hospitalized. If you go back to the 11th of January, we had 7,353 hospitalized. So over 800 fewer hospitalized patients January 19th versus January 11th. A very encouraging trend that I hope will continue, and I expect it will. So that's a good thing. And once again, we're not dealing with absolute numbers, but the percent positive rate in the state is slowly beginning to trend down as well, which is a good thing too. Here at CGH, how is the pandemic and the situation with the pandemic affecting us most acutely? Well, obviously, of course, people that are hospitalized. So we still have a number of patients who are hospitalized here with COVID that take extra time and resources in that you're having to do PPE every time you go in and out of the room and all those type of things. So that's definitely affecting the hospital. Of course, in terms of visitor policies, that affects affects the hospital, but it also affects our communities that we serve in terms of their ability to come in here and visit. And like all businesses right now during this particular wave, we have a number of staff that are either isolated or quarantined, and as a result of that, we're making it work, but it's been challenging at times getting everything staffed and taken care of. So, for instance, our Prophetstown and our Milledgeville clinics right now are temporarily closed just to help out with some of those staffing issues. Okay, that's CGH related stuff I wanted to share. Now, just some other pieces of information I thought were worth mentioning. So CDC continues to modify what their information about mask wearing, and here's what it boils down to. If you're going to wear a mask, cloth is not as good as surgical. Surgical is not as good as a KN95, and a KN95 is not as good as an N95. Yeah. So to the extent that I guess you have to decide on your situation, your risk factors, and those type of things. Definitely wear a mask. I think it makes sense to at least wear a surgical one, and then depending upon your risk factors and the situation you're in, the KN95 or N95 can be a really good fit too. And what we're seeing here at the hospital is that I think there was a viewer that asked this last week or the week before last about, are you seeing more asymptomatic patients show up? And the answer is yeah, both patients and mainly patients that we do a test and we're like, oh, yep, they didn't know they have it, but they have it. Sometimes that's in testing areas or those type of things. And the only reason I say that is that that's throughout the community. So the thing that I would, as I'm walking around and I'm going around in the community, the thing that I think I would keep in mind is that I would assume that if you're in a public space, that some of the people walking around in that public space have an active infection and are shedding virus and don't even realize it. So in terms of your mask wearing, I think I would wear my masks in knowledge of that. I would pick what kind of mask I would wear. And as I've been saying, if you fall in any of those risk categories, for right now, I think I would do a K95 or an N95 in those places. Okay. Obviously, other news that's come out this week is the White House has announced they're going to be sending out free COVID tests. And there's a website you can go to that gives you on how to get a hold of these free COVID tests. Excuse me, I got a little something in my throat here. And I think we're going to put up that website you can go to. Here's the deal. My understanding of those tests is these are antigen tests. That's what I'm hearing. Antigen tests for Omicron, not as effective. So if you get an antigen test sent to your home and you get a negative result, even if you're symptomatic, I would be really uncomfortable trusting that result. If you're symptomatic and you get a positive result, oh, thank you. Thanks, Matt. So if you're symptomatic and you have a positive result on an antigen test, I think you very much could assume that you should consider yourself as being positive for COVID. But negative testing, antigen testing, Omicron, not so great. So some other news that I wanted to make sure that I got out to you. And speaking of masking, I saw something today where starting in early February, folks can get up to three, every adult can get up to 3 N95 masks at select pharmacies. The government is going to be releasing 400 million N95 masks. So I'm thinking that here in this area, some of our retail pharmacies will have those in early February. I'm guessing they're going to put the word out, but as we hear about that becoming available, we will let you know as well. I thought this was another piece worth sharing. The CDC put out recently, they've now been able to, with Delta, the most prior to Omicron, the variant that went through is, let me put something down I forgot to mention I was going to say. Okay, anyhow, as far as Delta goes, the research would suggest that in terms of people that survived Delta infections, your chances were best if you had had a previous infection from another variant and been vaccinated. Your next best chance of surviving was to have had a previous infection. Your next best chance was to get vaccinated, to have been vaccinated. And then much, 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 much less, but not as good a chance if you're unvaccinated altogether and had not been exposed. So whether that will play out that way with Omicron or not, we shall see. Obviously, as we know, Omicron seems to break through much more easily to the folks who are vaccinated, particularly vaccinated and not boosted. So take home from that, yeah, if you'd had a natural infection, there's definitely some significant benefit in that. And if you get vaccinated, there's significant benefit in that. And then, yeah, because you ideally don't want to get a natural infection if you can avoid it, get vaccinated. Okay. And then I think the thing that I'm thinking about, right now is just, we should anticipate, you don't know for sure, but we should anticipate another variant will be coming. And I'm hoping, and hope is the operative word, but I'm hoping that we'll see that because people have been exposed to previous infections and or been vaccinated, and the variants also, if it follows the Omicron path, become less mean and nasty, if you will, that the next variant will be much more within that endemic, to use a term, realm where people get it, but far, far fewer people, even than Omicron, get sick. Time will tell. But right now we know that this particular variant is, I'm telling you what you already know. Very transmissible. People still get hospitalized with it. We continue to have patients, unfortunately, with this variant who don't do well. And we know that the number of deaths is, every day. I'm going to say, the number I'm looking at here is 1,796 deaths a day right now, although I would guess that would begin, that lags cases by about 3 weeks, but that'll begin trending down as well. One other thing I want to mention before I turn this over to our tape recording is I'm hearing, actually our marketing staff mentioned this to me, that they've been hearing some of this, that there are definitely folks, particularly folks who are more elderly and aren't able to get out, and or because of the pandemic don't feel comfortable getting out as much. And I just would encourage those who are listening and hear this to take the opportunity as much as you can to reach out to your neighbors and those around you who may be in that situation, as that obviously can be quite isolating and can cause loneliness and depression and those type of things as well. Oh, here's a question. As someone immunocompromised, I will assume we do for my 4th vaccine dose. Okay. Oh, thanks, Julie. Yeah, whether it's a full or partial dose, I can be honest with you, our staff at our vaccine clinic know that better than me. I'm just going to throw out, I think you get a full dose, but I'm not for sure on that. Our vaccine clinic folks can probably help you with that if you call our vaccine clinic at CGH, at the main clinic. Sorry, I don't have a for sure answer on that, but yeah, if you're more than 5 months out and you are someone who has an immunocompromised situation, yeah, more and more I think our medical staff are recommending that folks go forward and get that booster shot. Lauren, yeah, what kind of mask for kids? Yeah, I guess I would say, first of all, I'm hearing that the recommendations for under 2 years of age, that's pretty tough to keep a mask on. I'm amazed that kids 2 years and up do such a nice job with that. But I guess in general, I would say if a kid is otherwise healthy, a nice, if you can get a surgical mask for them, a pediatric size ones, that would be appropriate. If they have risk factors, then you, I guess, would potentially consider a K95, but otherwise, A well put together cloth mask would probably be reasonable for kids as well. But I guess that was a long answer. Short answer: surgical masks. Surgical mask if you can get one. Kimberly. If my sister loses her taste and smell and boyfriend had COVID, how long do they need to stay away from people? Yeah, so thanks for the question, Kimberly. So the issue there is not what symptoms someone continues to have after they have had an infection, because the reality is that taste and smell can, it could be a month, it could be a couple of weeks, it can be a month, it could be several months before that comes back. Same for other COVID related symptoms like fatigue, even a cough. I mean, it can linger. So once again, what we're really concerned about is whether someone would be shedding viral particles. And in that situation, I think right now the guidance from the CDC is 10 days of isolation. And then, because by the end of 10 days, you shouldn't be shedding any significant amount of viral particles. So given that fact, I think that a party's okay if they're more than 10 plus, if they're like 11 days out from their infection. Would I want to attend the party? Probably not. But in terms of is it reasonable from a CDC standpoint? Yes. Hope that answers that question. Kathy, a little too late. Yeah, Kathy, I hear you. So I guess it depends who you are in terms of the N95 being little too late. If you're somebody who is in a pretty low risk category, wearing a surgical mask is pretty reasonable. When you're out and about in public, I agree with you, Kathy. However, once again, if you're unvaccinated and you are someone who is in a higher, not only being unvaccinated, but other high risk type of categories, I don't think we're done. I don't think I would say the N95s would be out for them. I would say that, yeah, if someone's over the age of 65, they have any of the risk factors, and they're out and about in public, I think it'd be pretty reasonable to wear an N95 or a KN95 right now. Now you get a little, you get a month or two down the road, not so much. Would I think it have made sense to push N95s sooner than now? Yeah, I think it might have. And I don't know the reasons behind all that, but so I agree with your comment, and yet I think there are some nuances to who would still be a good fit. Alyssa, if there's a positive case in the house, how long should kids stay out of daycare? That is something that I tend to let the health department guide in terms of how long that should be. So, yeah, that's something the health department deals with on a day-to-day basis, and that would be something that is their lane. My lane is not all those. You look at all these tables and charts, I have to look them up myself. So sorry, I don't have a specific time frame for you. Any other questions? Well, as always, I thank you for taking the time to listen in, trying to give you up-to-date information and being as open and transparent as we can here at the hospital, and what's going on with us and what you can do as a community to help yourselves and help others around you to make it through this particular surge. So thanks for listening. And so what I'm going to do now, I'm going to transition into a taped interview with Dr. Alsayed, a new oncologist here at the hospital. And I talked to him several days ago. I thought it was really good conversation. This is our Growing Healthier series through the CGH Foundation. And our topic was latest advances in cancer treatment. And I think you're going to find it really interesting, some of the things that Dr. Alsayed brings up. So thanks for listening this week. We'll look forward to talking with you next week. Have a safe week. Thanks.
Hello, this is Sherry with the CGH Health Foundation, and this is our first Growing Healthier program. This is our speaker series for the new year, and for the next 3 months, we're going to be featuring some of our new providers. And today we have Dr. Alsayed in our oncology department. We'll be talking to Dr. Bird. He's going to be talking about new advances in cancer care and our newly expanded oncology space. And then in February, Dr. Kiso is one of our new interventional cardiologist. He will be talking about heart health. And then in March, we will have Dr. Alzubi from gastroenterology. Also in February, just to put it on your radar, we're doing a program for Heart Health Month. It's in February, and it's called Step It Up. And what we're doing is we're issuing a challenge to everyone in our communities to log their steps and check in and tell us how many steps they're doing every day. We're going to try to hit 1 million steps. So in heart health, a lot of times we're talking about nutrition. This year, we're going to talk about physical activity and how important it is for your heart. So please be watching for more information about how you can participate in that. And with that, I will turn it over to Dr. Bird.
Thanks, Sherry. I assume you're going to be giving them snowshoes if it's a little bit snowy out when they get their steps in.
No snowshoes.
No snowshoes?
Oh, you can't. I have snowshoes. I can do some of my steps on my snowshoes.
Okay.
Yeah.
All right. We just don't want them out when it's slippery.
No.
Okay. Are you going to account for the slipperiness in terms of how many steps if we have slippery days? Or
you don't have to do your steps outside.
So it's just
you can
1 million?
Do them on the treadmill. You
Okay,
can do them on the track.
Okay. All right. Just checking. All right. I'm clarifying with you, Sherry. Okay. Good. All right. Thanks, Sherry. All right. So Dr. Alsayed, I'm glad to have him here today. So Dr. Alsayed has been with us, I think, since late summer, and rave reviews from our patients in the oncology department, and great opportunity to have him here for 2022. And what we're going to be talking about are advances in cancer treatment. So what better person to have than someone who is in our department, who does a great job and is just done with his fellowship, who's been part of some of that kind of work, to have him on here to talk new advances in cancer treatment. So without further delay, let's get Dr. Alsayed in on the conversation. There he
is. Hey, Dr. Bird, how are you?
Good. How you doing, Dr. Alsayed?
I'm doing all right.
Good, good. All right. So I have a bunch of cancer questions, and what we're going to do is hit kind of some of the big bucket cancers that we see more of in terms of our conversation today. But I want to hit more of a personal note before we get into the questions about cancer. And the personal questions are for folks who haven't had a chance to meet you yet or know about you. So tell us what made you interested in getting into medicine, into a career in medicine in the first place, and then a little beyond that, even why taking care of patients who have cancer.
Okay, well, good afternoon, everyone. Thank you very much for having me today on the Facebook Live. I think it's a good opportunity to speak to the patients, and hopefully, we will learn more about cancers. First, my name is Alhareth Alsayed. A lot of my patients call me Dr. Al. I joined CGH in August of 2021, and I've been part of the team. And I'm so glad to be able to serve the Sauk Valley community. To answer your question, Dr. Bird, why medicine? I actually have a big family with so many family members working in medicine. Probably over 20 physicians in my family.
Wow.
Yeah. My grandpa was one of the first pharmacists in our hometown, but my actual inspiration is my mother. She's also a physician. She's a pediatrician, and she devoted all her life to serve or to take care of sick kids. And she's actually currently working with the United Nations in war-torn areas. So she is definitely my role model.
Yeah. So oncology, what kind of leans you in that direction?
So I mean, honestly, any oncologist you will ask, they will have a very similar answer, which is they came into a family member who had cancer in the past, and that goes for me as well. When I was in high school, one family member was diagnosed with acute leukemia and sadly passed away shortly after that. And this is when I started becoming very interested in cancer. Then after medical school, I was lucky to be able to work in a cancer research lab for about 2 years at the University of Illinois and then at the University of Chicago. And, I got to study the biology of cancer and how the new treatments are being developed. And, that, broadened my spectrum and gave me insight. And then after that, I decided that it is time to become more clinical. So I applied for residency and fellowship in oncology, and here I am.
Yeah, here we are. Glad to have you. Okay, so speaking of new treatments, are you ready to get into it with some
Yep.
new treatments? All right. Okay.
Good.
So let's start with breast cancer. So have there been any changes in the ways in which women are recommended to have chemotherapy and or radiation therapy in the past few years?
Yes, but let me just start by saying that when we choose a patient who will receive chemotherapy or radiation therapy, of course, after surgery, this is kind of a clinical decision. So, it's a decision that, we make after a long discussion with the patient and, discussing the risks and the benefits. So, so, then after that, if we decide that we might proceed with that route, then now we have few more tools that we can use to help us make that decision. In the past few years, so many tests have been approved, but I think most oncologists will agree on a test called 21 gene testing or Oncotype DX. So, like a patient who undergoes surgery and then we want to decide if the patient will be receiving chemo or not, we run this panel of genes and use PCR to measure the expression of 21 genes, and that we come up with a score for the disease recurrence or the risk of recurrence score, and that will help us, which patient will likely benefit from chemotherapy after. But there are multiple other tests that was just an example.
Yeah, I've just noticed here in the last several years when I've heard discussion on a tumor board about patients that have breast cancer, it's a lot more conversation about this genetic makeup of the cancer than I remember, let's say 10 years ago.
Yeah, that's true.
Yeah. So is the size of the tumor still part of that decision making in terms of whether or not the patient would need to have certain treatments or not?
Yes, absolutely. We still, for most cancers, we still use the size of the tumor, the lymph node, regional lymph node involvement, and also the extent of the disease or spread to different organs to figure out the stage of the cancer, and that can be very helpful in figuring out the prognosis of the disease and also the treatment modalities that we are going to choose. Now, for breast cancer, we use 0.5 or half centimeter as a cutoff, and also involvement of lymph nodes to where we use it as a cutoff to when we consider using what we call it adjuvant chemotherapy after surgery. But yeah, still size and lymph nodes are very important factors in breast cancer.
All right. So as far as breast cancer goes, have there been any? But now that you're doing these genetic tests on these tumors, have there been, as a result of that, any categories of breast cancer where you've begun to see their survival or the life expectancy prognosis, if you will, improve significantly in the last few years?
Yes, so definitely, first let me just speak a little bit about genetic testing. So there are two types of genetic testing that's separate from the test we talked about earlier
Okay.
to determine which patients will receive adjuvant chemotherapy. So genetic testing is different, thing. So we have two types of tests. The first test is the conventional genetic testing. So we check the DNA, the normal DNA of the patient, and we see if they carry one of those mutations that put the patient at higher risk of developing cancer, such as, I'm pretty sure a lot of people heard about BRCA1, BRCA2, or BRCA1, BRCA2. If someone carry those mutations, they will be at risk of developing breast cancer, ovarian, pancreatic cancer, melanomas at a very young age. So that's important because people who carry those mutations, now we can treat them with a new class of drugs called PARP inhibitors. So we have options for treatment for those patients if it happens and they develop a cancer. Now, the other type of genetic testing is what we call next generation sequencing. So what we do in this test is we sequence the DNA of the cancer cells, not the normal cells, that not the our normal DNA. No,
Okay.
we sequence the cancer cells, and then we look for mutations that we can target, with new drugs that are available for us. So that's the difference between the two tests. Now,
Okay.
as I said, for the genetic testing, if somebody carry one of those mutations, then we have PARP inhibitors. In next generation sequencing, that opens the door for so many treatment options. And a very common mutation that we found in hormone positive breast cancer is PI3K mutation. I'm pretty sure many people have seen the drug or the new medicine advertisement on TV, Piqray, and that this drug is an inhibitor for that mutation.
Okay. So what does that mean for a patient? Let's say that they have that mutation and they're a candidate for that drug. What does that mean in terms of what they would have expected before we were able to identify that mutation and give that drug in terms of their prognosis? I'm saying the prognosis before, and now that we have these new options, what does that do for their prognosis?
Right. So, this is the future of oncology, or what I like to call precision oncology. But we still, of course, our standard of care most of the time is systemic therapy with chemotherapy or immunotherapy. But I think in the near future, our treatment is gonna be more targeted and so much individualized, for depending on the genetic testing for every patient. Um, other Speaking of change in the prognosis, there is a very good example in that a lot of oncologists talk about in breast cancer. In patient who has HER2 receptor positivity, it's a receptor that's found on breast cancer in about one third of the cases. So people who have HER2 positivity, back in the days, it used to predict a very poor prognosis, and those patients did not respond well to treatment, and it was very challenging treating them. Nowadays, it's actually predicts more favorable prognosis because of the explosion in the new drugs that target HER2 that we have. So, we can go from one line of therapy to another line, and we have so many options.
Okay. Yeah, that sounds really encouraging. So you're talking to someone who otherwise may have, I don't know, months of life expectancy. We can push that back some years or.
Yes, definitely. We're talking about several years, 3, 4, 5 years, when we're speaking about patients who have metastatic disease, where the cancer spread outside the breast and went to different organs, such as the lungs or the liver. And we have so many patients who are receiving treatments against anti-HER2, and they're very effective, and their life expectancy is much longer than what it used to be.
Yeah, that's really encouraging. Let's move on to lung cancer, another one of the big cancers that we see in our country. I'm going to start on something that's actually not a treatment. It's more of a test. So can you talk a little bit about, what are the latest recommendations on the screening lung cancer CT test. We have that here at the hospital. That's the reason I ask it. What are your thoughts on that, Dr. Al?
So there are so many guidelines that people follow, but I think me personally and most of the physicians that I know, we use either and I'm pretty sure you're familiar with it, either the U.S. Preventive Service Task Force,
Right.
or the American Cancer Society, and they both recommend to do annual screening with a low dose CT scan, so once a year, and the target age is 50 to 80 years old, and that's in people who are currently smokers or have smoked in the past 15 years,
Yeah.
and they have smoked more than 20 pack per year. And when I say 20 pack per year, doesn't mean only 20 packs every year, but it means the number of packs smoked every day over the number of years. A good example is somebody who smokes 1 pack per day for 20 years. That's 20 pack year. So yeah, so age 50 to 80, once a year, low dose CT scan for people who are currently smokers or have smoked in the past 15 years.
Curious about something with that. Between you or Dr. Ali Khan, we've been probably doing that screening here at the hospital for, I don't know, 2 years, 3 years. I lose track of time sometimes. Have you seen any trends towards seeing patients who show up who have smaller tumors that were caught on the lung CT scan screen?
Yeah, yes, for sure. I haven't been here for a very long time, but already I have seen few patients who were referred to me due to small nodules or suspicious lesions that were found on the low dose CT scan.
What does that mean in terms of a patient's prognosis if you catch something on a CT scan like that?
It changes the whole management. We're talking about first stage lung cancer or maybe second stage lung cancer, which we can just go and do a surgery and take it out and call it a day, rather than waiting, and then the cancer is bigger and spread to different organs, and then surgery or cure is not an option anymore, and we're talking only about palliative measures or treatments just to prolong life. So it's a big difference between people who undergo screening and we catch it in a very early stage.
Yeah, I just wanted to clarify that for folks who are listening. So we talked about genetic testing for breast cancer. My hunch is there's probably some genetic testing going on in lung cancer treatment as well. Can you talk a little bit about that for us?
Yeah, so actually, genetic testing or next generation sequencing is kind of the cornerstone for lung cancer right now for treatment. If I see a new patient, with non-small cell lung cancer, and I decide that I want to treat them with chemotherapy, most insurance companies won't even cover my therapy because I haven't tested them for genetic sequencing or next generation sequencing. We test a panel that is actually growing every day of mutations, and we have a lot of new treatments that target those mutations. It changed the whole management of lung cancer.
And I'm sure at CGH we do all those treatments that you would probably get at some big center.
Yeah, yes, we do. Actually, those treatments that target certain mutations, most of them are oral medications,
Okay.
compared to doing chemotherapy, which is an infusion, and the patient will need a port, for admission. Most of those tests are only, most of those drugs are only pills, and it makes the patient's life much easier. Now, unfortunately, it's not very common. I would say about 15 to 20% of patients will have a targetable mutation that we can find, but I think it's worth looking at that in every patient. That's going to change the prognosis significantly.
Yeah. So once again, and I think I'm probably by the end of this interview, we're going to be a broken record. But so you're once again in those kind of situations, you're literally talking, instead of months, you're talking perhaps even period of years, that if you have if you're a good fit with the mutation and the medicines available to target that cancer.
Yes, yes. Back in the days, people with metastatic lung cancer, like lung cancer that went outside of the lungs to different organs, we used to talk about months, maybe 1 year, sometimes 1.5 year. Nowadays, if somebody has an I'll give you examples. Somebody has an EGFR mutation, and we put them on a new treatment that targets this mutation. It's called osimertinib. The papers that we are getting now, they're talking about 48 months survival, 4 years, of disease control. This is amazing. This is the future.
Yeah. Yeah. Anything else about lung cancer that you wanted to share with folks?
There's a lot of advances, on lung cancer, and actually there is now more data to suggest using this genetic sequencing or next generation sequencing even in the early stages. As I said, it's the cornerstone of treatment of metastatic disease. But now we're having more, clinical trials showing clear benefit in the early stages, and even using some of those targetable or targeted therapies in the early stages, where we're looking for cure. So there is a lot of data coming in lung cancer.
Good, thanks. Okay, now we're going to go on to another common one. Let's talk about colon cancer. So, surgery typically happens with colon cancer because you're wanting to get that tumor out. You don't want it to be there and hang out. Any changes in terms of the timing of when patients get the surgery done for them, either before or after any sort of treatments?
Actually, it's still the surgery. We still start off with surgery first, and this is the preferred way to treat colon cancer, because depending on the findings on the surgery, the tumor size, the number of lymph nodes that are involved, and some high risk features that the pathologist can report to us. Depending on those findings, we will decide on what type of chemotherapy and the length of chemotherapy treatment that we're going to do after the surgery. Now, there are a few cases where we sometimes prefer to start with chemotherapy, and I'll give an example. Somebody who has a large tumor or tumor invading, the organs in the abdomen, where the surgeon will think, they cannot do surgery to take everything out. So we will then give, a few months of chemotherapy and hoping to shrink the tumor a little bit where surgery can be feasible. Now, those needs to be looked at case by case and discussed in multidisciplinary tumor board, and it shouldn't be. This is not the standard of care, but surgery first is what we do right now.
Yeah, and like I said, I'm asking similar questions for each type of cancer, but just can you speak a little bit to some of the advances that we're seeing in the treatment of colon cancer?
Yes, we utilize the same testing that I was talking about, the next generation sequencing, and we look for certain types of mutations. It's a little bit different than the ones we find in lung cancer, but such as KRAS and RAS. A lot of people who have colon cancer know about them, and BRAF. And depending on the positivity or finding those mutations, then we will decide on certain treatments that are got approved in the recent few years, as a addition to the chemotherapy or as single agents. And also the new thing in colon cancer is the use of immunotherapy.
Okay.
Now, not all colon cancer patients are candidates for immunotherapy, but what we do a special testing called microsatellite instability, and this is a test the pathologist do on the tumor sample from surgery, and depending if that's if we find that, then the patient will be a candidate for immunotherapy. And patients respond in a very nice way, and they have very durable response. I was talking to Dr. Ali Khan a couple of days ago. He has few patients that were on treatment for 2 years, and then he stopped the treatment because there's no signs of cancer after that.
Wow.
So it is the future.
Yeah. Follow-up question in terms of the mutation. So, like, how does that go? Like, if you're treating someone with, let's say, immunotherapy, and they're doing really well, and then let's say you start to see when you're doing your scans, you start to see some tumor growing back. Do you reanalyze that to see if there are even more mutations happening in that patient in that situation?
Yeah, so this is evolving every day, and it's kind of at this time everybody has their own style of doing it. I go ahead and analyze the mutations one more time if I have a disease progression, because what happens sometimes is people develop new mutations or lose the mutations that they had before. So
Yeah.
it's good to have an idea of what happened over there. Now we always, when one treatment is not, the patient is not responding to one treatment, we can always use, if the mutation is still there, we can use another medication to target the mutation, or we can use the standard of care. There's the chemotherapy and plus or minus immunotherapy to treat that, just like the same as we treat patients who don't have mutations.
Yeah. So immunotherapy, and I think of one of the cancers that I've heard of first where this was really helpful for, I'm going to transition to, is melanoma.
Yes.
Can you talk a little bit about what's going on with immunotherapy and melanoma?
So actually, immunotherapy was first approved for cancer treatment in melanoma. That was around 2014 or 2015, 7, 8 years ago. And then we did not have any good options to treat metastatic melanoma. Melanoma that went to other organs, and all the treatments that we had were very poor choices, unfortunately. And then immunotherapy therapy came to play, and then that changed the whole spectrum of treatment for melanoma. Now, immunotherapy is the first line for treatment for melanoma. We can use multiple agents. Either we can use two agents at the same time or a single agent, and it's an infusion that we give once every 3 or every 4 weeks, and we have very significantly good results with the use of immunotherapy in melanoma. Now, there is another indication for immunotherapy in melanoma, which is in stage 3, where the melanoma went only to the lymph nodes, and we give 1 year of immunotherapy after surgery. And actually, I just learned a couple days ago that there is new data coming about using it in earlier stages of melanoma, such as stage 2. And it's still not on the guidelines, but I think it's going to be coming to practice in the near future. So
What's the thinking behind doing it even earlier and earlier if you have less severe stages like 2 or 3? What's the thought process with the immunotherapy?
the thought process is prevent recurrence for sure. They compare patients who just went through surgery versus patients who got surgery and then received about 1 year of immunotherapy. And they found that patients who received the immunotherapy, the chances of the cancer coming back is lower. So it kind of prevent the cancer from coming back.
Yeah. Okay. And then besides immunotherapy, are there any other treatments in melanoma that we're using quite commonly these days?
Yes, we do. The other very good option for melanoma is what we call them BRAF inhibitors. So they target a certain mutation that's found in about half the cases of melanoma. It's called BRAF. And those medications are pills as well. They're once or twice a day, and they have a very good response rate and a very good control of the disease, and they prolong the survival of the patient in a very nice way.
Okay, good. So that's a lot of great information about particular cancers. And what I'd like to do here just for a few more minutes is kind of hit on maybe not the cancers themselves, but some different kind of things that we're doing around cancer. So I want to start with PET scans.
Mm-hmm.
So people may or may not have heard of these. Would you talk a little bit, Dr. Alsayed, what exactly are PET scans and what are you using them for? And are you using them more now than you used to, and why? A lot of questions in there.
Yeah. So PET scans are a specialized type of CT scans. We use a special dye called the tracer, and we inject it in the veins before the scan, and then the tracer goes to our tissues. but it's more collected in tissues that have higher metabolic rate. And cancer cells by default, they have higher metabolic rate than normal tissue. So when we inject the dye and then we do the scan, we can pinpoint to the cancer, where the cancer is or where the masses is. So it's a very useful, if you look at the scan after somebody has cancer, you give them the dye, and then you look at the scan, you'll see areas where they light up on the scan, they look orange, and that's where the cancer is. Now, how do we use them in cancer care? They're very useful. We definitely don't use them in every type of cancer, but I would say in most of them. And they're very useful at the beginning. If we have let's say we talked earlier about lung nodule. Somebody undergoes screening lung, low dose CT scan, and we find that they have a small mass that we are not sure how significant that is. So then we will do a PET scan, and if that nodule or mass light up on the PET scan, then that should be very concerning and warranting further workup such as biopsy or resection.
Okay.
So they're very important, in the diagnosis, also in coming up with the stage of cancer by checking the spread or determining the spread, how where the cancer has spread to, and also they're important in the follow-up care. After we start treatment, we can check on the treatment effect, and we can check for disease recurrence with PET scans.
Yeah, good. Okay, next topic. Kind of a lay term that you read about. If you read kind of scientific kind of magazines or the science section of just a general magazine, liquid biopsies. What are we talking about here? Is that what we're talking about with genetic testing, or is it something else? And I'll just let you kind of speak about these liquid biopsies.
So liquid biopsies are a very new technology that came in the past 4 or 5 years. So when you think about it, they're very similar to the next generation sequencing that I was talking about. The only difference is in next generation sequencing, we need a tissue biopsy. So we need a piece of the tumor or the mass or the cancer, to analyze the genetic DNA. Now, in liquid biopsy, all we need is a blood sample. So we collect a blood sample, and then we send it to. There are multiple companies that can do that right now for us, and we send it to one of those companies. And it's a very cool technology. So they detect the cancer DNA that's circulating in the bloodstream, and then they analyze the DNA looking for mutations or for mutations to target. So this is the difference between them. When we use them, we pretty much use them on all metastatic cancers when we cannot get a biopsy or when the biopsy is very difficult or high risk.
Okay.
And also, there's another new indication for them. I'll give you an example just to make it easier. Somebody with colon cancer, they undergo surgery, and then we are trying to decide if we're going to need more chemotherapy or not. So we check the blood sample and we check if they have circulating tumor DNA, that broke off of the main tumor. Then, they might be candidates for more chemotherapy to hopefully kill if there's any tumor deposit anywhere else. It's still not 100% validated and still, within clinical trials, but that's going to be the future, I think.
Do you see a future for it, for just like, I don't know, so someone who just is in their 50s and just wants to see if they have anything going on, and they would go to their primary care doc and do a liquid biopsy? Do you see a future for that? Or is it still, do you think it's going to remain more in the oncology space for the near future?
I think it's very premature to use them for screening, if that's what you are referring to.
Yes, right. That's what I'm referring to.
Just think about it this way, the same as the pan scan that, I think people used to talk about in the past. Somebody goes and they get CAT scans from head to toe, without having symptoms, and how many, false findings that you can find. Same with the liquid biopsy. Now, if you check somebody's and you find that you find that they have a mutation, but you cannot find the cancer, what are you going to do with that piece of information? So I think it's really premature to use them in screening for cancer.
Okay. Okay. Good. Thank you. Now, next topic. Stem cell transplants in particular. So what is it? Because people probably have heard of that a lot in the lay press. And then what kind of cancers is it being used for these days?
So stem cell transplant or bone marrow transplant, as some people call them. So basically, it's a therapy for cancer. Basically, the way it's done is we have what we call stem cells inside our bone marrow, and they are the mother of all the blood cells. They divide and differentiate into blood cells. So what we do is we collect a sample of those stem cells, and then we collect them and put them outside the body and freeze them, and then we will give a very high dose of chemotherapy with or without radiation therapy to hopefully treat the cancer or kill all the cancer cells in our body. And as a side effect, what happens is we kill the cells in the bone marrow, including the stem cells. So, but if we took the sample earlier and froze it, then we can reintroduce it, and then it will go to the bone marrow, and when we will have our blood making working again. So that's the main concept of stem cell transplant. There are two types of stem cell transplant. There's auto transplant, which means that we got the stem cells from the same patient and froze it. And there's allo transplant, which means that we got stem cells from a donor who's a matching donor. Most of the time would be a sibling or a family member. Now, you asked me where we use them.
Yeah.
Very commonly, they are used in hematological cancers or blood cancers, acute leukemias, certain types of lymphomas, such as Hodgkin lymphoma or mantle cell lymphoma. Multiple myeloma, for sure, is one of the cancers that we always transplant. Mainly in the blood cancers. They have been studied in solid tumors, such as in breast cancer and sarcoma, but the data is very conflicting, and still, if it's done, it's usually done under clinical trials in very big tertiary centers.
Okay. How do you, one other follow-up question on that. How do you decide whether someone's going to get an autograft or an allograft bone marrow transplant?
Well, that mainly depends on the type of the cancer. So multiple myeloma patients, most of the time they get auto transplant. We collect their stem cells and transplant them. Patients with leukemia, acute leukemias, most of the time they would get allo transplant. It's just because of the biology of the disease, and when there's a cancer cell in the bone marrow itself, or there is a concern about cancer, in the stem cells, then that's what makes us decide which way we go.
Got it. Very good. Well, it seems like this is if I were you, this is a good time to be getting into and to be starting a career in oncology, because there's so many things that are happening, so many new opportunities to help patients out that seem like are just really exploding right now.
You are absolutely right. The future is going to be in oncology. We have a new drug coming on the market almost every day, maybe every week. We have a new combination of a drug or a new indication of a drug that we have. There is so much information coming right now, and so many treatment options, and I think in a few years, hopefully we're going to be able to treat cancer as a chronic disease, more or less.
Yeah, that's great news. Really good news. Yeah. So and the other thing I just thought as we're talking here, it's so nice to talk with you, Dr. Alsayed. For the folks who haven't met you, you're such a nice guy. And it's just a great fit because Dr. Ali Khan is such a great guy too. That must be a nice experience so far to be working with Dr. Ali Khan and the rest of the team that we have there in our oncology department.
Yes, I was very impressed, and I'll say that in here, with Dr. Ali Khan when I joined. I mean, he's the best partner that I would hope for. He's very nice, very friendly, he's very knowledgeable. So it's really good. As I said, there are so many changes in the field, and it's good to have somebody you can talk to or share, new information with, or it's really good to have someone like Dr. Ali Khan and the whole team at CGH at the Cancer Center. I mean, I'm so proud of them. They are very devoted to helping our patients, and I cannot express how impressed I am with all of them.
Yeah, and I would say for them likewise for you, how they feel about you. So it's great to have you. And just for folks, before I let Dr. Alsayed out of here, he does see patients in Sterling, yes, but he also does see patients in Dixon as well. As a matter of fact, I think you told me you're in the Dixon office this afternoon right now.
Yes. So I'm in Dixon office on Tuesdays and Wednesdays, full day, and then I'm in Sterling's office on Thursdays and Fridays every week.
Great. Good. Well, I'm glad we had a chance to do this, Dr. Alsayed. Been great talking with you. Maybe we'll even get you back sometime. What do you think?
Oh yes, for sure. Yeah, we can talk more for sure. I mean,
All right, great.
There are so many things to talk about in oncology.
Yeah.
I can keep going on for a few more hours.
Well, we'll cap it at 30 or 40 minutes. We appreciate your time. Great to have you, and yeah, good conversation.
Thank you very much. Thank you for having me.